So we go to the last topic of the session by Professor Thammawat Parakonthun. Professor Thammawat has graduated from Sirat Hospital, Mahidol University, and he is training in both in Japan and in German for the gastric cancer surgery from Tokyo Medical Dental University and Heidelberg in Germany. So now he is an associate professor at the Department of the Surgery, Sirat Hospital. So please, Professor, today the topic is the role of the lymphadenectomy for gastric cancer. Please.
Thank you, Mr. Chairman, for your kind introduction. Good morning, Professor, and all participants. Today, I'm going to talk about the role of lymphadenectomy for gastric cancer. So everyone knows that gastric cancer is one of the lethal disease. It is very harmful, and it is the third leading cause of cancer-related deaths worldwide. And one of the most important prognostic factor is a lymph node metastasis. So we have to learn how to secure this kind of spreading. And the lymph node metastasis is not only the key component factors for staging, but it also the components of recurrence and survival prognosis. So we have to know about the extent of lymphadenectomy in gastric cancer. Japanese Gastric Cancer Association classified the lymph node according to the location of the station away from the primary tumor site, and they recommend the lymph node dissection along with this kind of classification. We can remember easily by using this station 1 to 6, means that the lymph node is located along the perigastric area. Number 7 to 12 is the lymph node, which is located along the main arteries. And the faraway lymph node is the lymph node number 13 to 16. The lymphatic spread is moving from inside to outside, from the perigastric area to the distant area. So the knowledge of the anatomy is very important to make a safe procedure and make an adequate lymph node dissection. Currently, we perform our surgery according to this kind of guidelines. The standard gastrectomy is separate to the total gastrectomy and the distal gastrectomy. We remove the perigastric lymph nodes in blue, which is the one for the early gastric cancer. For the more advanced disease, we remove the orange and pink one according to the kind of gastrectomy. But we can make some more modification for the early or very small tumor size, which is a modification of gastrectomy. In the past, D2 lymphadenectomy is a standard treatment for the Japanese and Korean surgeon. They can perform with very fantastic results. It shows very good prognosis with very low morbidity. So we agree with this radical surgery, and after remove all the tumor and lymph node, we decide to give the patients adjuvant chemotherapy according to the staging. In the West, they try to do this kind of procedure, but with the low number of the patients and less experience than in the East. The results from the landmark paper from UK, which is MRC, and the Netherlands, which is Dutch D1, D2 trial, demonstrate very high morbidity and mortality after D2 dissection. But these studies could not demonstrate the benefit of 5-year survival. So they seek to to find some more surgical for more optional treatment, for example, perioperative chemotherapy or adjuvant chemoradiation. At the beginning of an English version of Japanese gastric cancer treatment guidelines, they used the very complicated data to recommend the lymphadenectomy. They recommend using this table to remove the lymph node according to the primary tumor. But it was very difficult to remember, and it was very complicated to do the surgery according to this recommendation. And Japanese noticed they adapt their recommendation to the simplified version. They recommend lymphadenectomy according to the extent of gastrectomy, which is more comfortable to the surgeon worldwide. And after that, this procedure is widely accepted not only in the East but also in the West. If you can remember the Dutch D1, D2 trial, which demonstrate very high morbidity, but this could not demonstrate an oncological benefit. But for a very long 15-year follow-up, this trial demonstrate a very low incidence of death after D2 dissection compared with D1 in the gastric cancer-related death, and lower recurrence, local regional recurrence. So after these results, the D2 lymphadenectomy is recommended to the Western country. One of an interesting study is Logica trial. They interest in the neoadjuvant chemotherapy, but they also demonstrate very important results, which is the prevalence of lymph node metastasis. And they found that for the diffuse type, the incidence of lymph node metastasis is higher than intestinal type. And the lymphatic spread is not located only near the primary tumor, but they can also spread to the faraway region. And the clinical T stage did not limit the incidence of lymph node metastasis. So they recommend that although a patient got the neoadjuvant chemotherapy before surgery, D2 lymphadenectomy is routinely performed after the chemotherapy. Neoadjuvant chemotherapy cannot reduce the extent of lymph node dissection for the Western patient. Should we do more than D2? This is the landmark, JCOC 9501. They show that for the patient, they randomize the patient with D2 and D2 plus para-aortic node dissection. The result could not demonstrate the survival benefit, but the morbidity after D2 plus para-aortic node dissection is higher. So routine prophylactic D2 plus para-aortic node dissection could not be recommended. But some studies demonstrate the survival benefit after neoadjuvant S1 and cisplatin. But this is recommended for very selected patients in high volume center. I hope I thought that you familiar with these guidelines. So the D2 is recommended for more than T2 and N positive patients, but the Japanese guideline recommend some modification for the gastric cancer patients, also in the Korean guidelines. And the ESMO, although they emphasize the using of perioperative chemotherapy, but they also recommend the D2 lymphadenectomy in their guidelines. So the current guidelines, D2 lymphadenectomy is the standard for the resectable stage 1B to stage 3 gastric cancer. And they should be performed without routine splenectomy with pancreatectomy to reduce the postoperative morbidity. And the D1 and D1 plus can be acceptable for an early stage or some patients with very high medical risk. D3 is not routinely recommended, but can be used in very selected patients with very experienced surgeon in high volume center. Talking about the minimally invasive approach, the earlier study is related to the distal gastrectomy. The Korean study compared the short-term and long-term outcome, comparing the lap distal gastrectomy with the open distal gastrectomy, and the results demonstrate low complication after surgery, and also the comparable survival outcome. Also, the Japanese study demonstrate the same results. For the total gastrectomy in a very high volume center, they demonstrate in the same direction. Short and long-term outcome is better in the laparoscopic total gastrectomy. For an advanced gastric cancer, the class 2 type is the landmark. They demonstrate better short and long-term outcome. However, the 3-year survival is comparable to the open group. Also, in the Chinese study, they demonstrate the same results. So one of the important question is how many lymph nodes should be removed during the surgery. Most of the recommendation said we should remove at least 15 lymph nodes to adequate staging. But the more lymph node removed, the more better results is demonstrated also in the retrospective study. But number is not the only factor. The knowledge of anatomy and the exposure is very important to remove the lymph node along the vessels, not only in the open, but also in the minimal invasive surgery. So my conclusion is lymphadenectomy is very important for staging and oncological clearance. D2 nowadays is a gold standard for resectable stage 1B to stage 3. And the modification of lymphadenectomy D1 or D1 plus can be acceptable for an early stage or very high medical comorbidities. This should be performed by avoiding the unnecessary splenectomy or pancreatectomy. The knowledge of anatomy and technical skill is very important for doing this kind of procedure to make sure that the post-operative morbidity is lower and better results in terms of oncological outcome. And minimally invasive surgery can be performed in high volume center. And we have to focus not only in the surgical technique, but we have to discuss with our multidisciplinary team. Thank you for your kind attention.
Okay. Thank you, professors. So right now there's 2 questions from the online. So may I ask first? The first question may be for the Professor Jirawat and Professor Prasit. He's asked about the guideline for the ESD in Thailand for the size of the lesion, the depth, and the use of the role of the EUS prior to ESD, or the ESD before or the after confirm the diagnosis by biopsies. Please, Professor.
Yeah. In Thailand, mostly of the endoscopists follow the guideline from the Japan, and we assess the lesion by endoscopy, and we use the technique by the endoscopy to see this lesion is suitable for the endoscopic resection by the Paris classification. If you see the type 0 from the Paris classification, that means the lesion is suitable. If you have the question, you use the technique by the suction and see the lesion that can move from the muscular layer or not. And in the case of we did not sure, the EUS is helpful for the patient in this situation. Or the pathological result before in gastric cancer in early stage before going to decision for the endoscopic resection. I think it's need because of in the detail from in one of the factors to decision for the endoscopic resection is the differentiate or undifferentiate. We use the biopsy before we decision for the treatment, and in many of the doctors they are concerned about the after the biopsy the ESD is more difficult or not. I think in this issue you can use the biopsy, and when do dissection in this area that you biopsy before, you have to perform in the more careful. And when you injection and this area is not lifting lesion, sometimes we mean that the lesion is not suitable for the ESD because the lesion is attached to the muscularis propria. But if you have the pictures or the data before that, this area is biopsy area. I think it's not the cancer, but this is the fibrosis from the biopsy, because some of the doctors they use the big bite that can create the fibrosis. I think in Thailand we did not have the guideline, but we follows the knowledge and the main idea from the Japan that used to estimate in the size, the depth of the invasion, the ulcers, and differentiate from the pathological results.
Thank you, Professor. Any comment for Professor Jirawat?
Thank you, Professor Visit. About gastric ESD, one point is important is when you're looking for the lesion, you have to observe entire the lesion, because of sometimes in one lesion have a various of the depth, maybe shallow or deep. So the deepest point is to determine the diagnosis and to link it with the treatment. And another point is the problem that I met is the small, very small lesion and was biopsy from another hospital, and when sent to me, the lesion was disappear. So when you suspicious the lesion and it very small and maybe disappear from the biopsy, so I maybe recommend you maybe be careful to biopsy of the entire lesion, and maybe biopsy at the border include of normal with the abnormal, and you have to observe where is the exactly location for transfer or for follow up after biopsy, because of after biopsy when it disappear and you send to another hospital or expert, the expert cannot when we don't know where is the primary lesion, so it's very important point. Thank you very much.
Thank you, Professor Jirawat.
Okay,
Please,
I have one comment from Japanese side. Another question is the indication of the ESD can be expanded for the elderly patient. So age is one of the essential factor for the indication of the ESD. So and now Japan, we are going to the trial for the feasibility of the expanded indication of the ESD for the elderly patient. 80 years old ago. That's a comment.
Okay, thank you, Professor. So the second question for the D2 lymph node dissection, do you recommend to dissect the vein first or the artery first, especially for the infrapyloric lymph node, which is easier for bleeding? And the second, how do you control the bleeding from the pancreatic vein, especially for the D2 around the dissect around the pancreas? And the role of the ICGs for the identified vessels. So please, Professor Eto and Professor Thammawat.
May I answer first? From my practice, I think controlling the vein first is easier because when you approach from the laparoscopic view, we usually see vein in front of the arteries. And the second question is how to prevent from how to control the bleeding from pancreatic vein, right? The first is not to injure it. So you have to clearly identify the anatomy, clearly make a dissection plan, and keep the neurovascular bundle. You have to dissect superficially to this neurovascular bundle to prevent from injury. But if the injury occurs, it is harvesting situation. So we have to think about the vascular control. We may have to use the vascular appliance like a bulldog clamp. Cross finger, I have never experienced this. But in case of uncontrolled bleeding, we may have to convert to open surgery.
Okay, any comments from Professor Eto?
Okay, so the same comment. That's, the very most important point is to keep the adequate lymph node dissection lines we call the outermost layers, just outside of the nerve sheath around the artery. That's very important. And the recovery procedure is depend on the situation. Yes.
Thank you, Professor. Any comments from the on-site audience? So if no comments, maybe I would like to close this section. So the next is a break for the lunch. So before going to the lunch, we will have take a group photo again in the first floor, please. Thank you.